Welcome, everyone. My name is Chiquita Paula de Souza. I'm one of the education chairs on the American Academy of Pediatrics section on Global Health Executive Committee. I'm pleased to introduce you to the next webinar in the AAP Global COVID series, Global Health Practice in the Time of COVID, Finding Effectiveness in Your Personal and Professional World. Our third webinar, hosted by the AAP section on Global Health in partnership with Baylor College of Medicine International Pediatric AIDS Initiative at Texas Children's Hospital, Save the Children, and MSF, will begin shortly. We have no conflicts of interest to disclose. The webinar will begin with panelist presentations followed by Q&A. Please feel free to submit any questions that you have at any time during the presentation, and just make sure to select before you send it, select to all panelists so that we see it and we don't miss any questions. Before proceeding, I'd like to just have everyone please save the date and time for our next webinar. So here's a little flyer of the exciting lineup that we have for our next webinar on July 14th on health disparities locally and globally, where to start. So definitely keep that on your calendar and look out for an invitation link to register for that. I will now hand over to our moderator for the session, Dr. Patterson, who is AAP Senior Vice President for Global Child Health and Life Support, and she will introduce all our panelists. Thank you, Dr. Patterson.
Thank you so much, Dr. Paula de Souza. It's really exciting to be here with so many fabulous panelists who have experience in so many different parts of the world. I think many of us through this COVID pandemic have been struggling to figure out how to do good work in our own lives and manage our own households, but worrying very much about how we can support our partners in other countries and how we can do that without travel and hearing more about people's needs and experiences. So I'm really pleased that we're going to be able to hear from people in 3 different settings today about their experiences during this difficult time. So it's my pleasure to introduce the first speaker, Dr. Kemi Ogundipe, who is the Child Health and Pediatric Advisor for Doctors Without Borders, or Médecins Sans Frontières, and she'll share a bit of her experience with us now. Thank you so much. Over to you, Dr. Kim.
Thank you, Dr. Patterson. Hello, everyone. I'm Dr. Ogundipe. As mentioned, I'm a pediatric advisor for MSF, and I'm based in Belgium. So today I wanted to talk a little bit about the what we're seeing in our projects and how we're supporting them in continuing care for children in their settings. A brief overview of what we are currently doing in MSF for COVID-19. As of the middle of last month, we were supporting COVID-19 projects in about 30 countries, and we had screened about 6,000 people for COVID-19. Of that, nearly 2,000 of them were either found to have confirmed probable or suspect COVID-19 and were admitted. And among this group, there was about 7% of them who was aged 0 to 15 years. As of the time of this report, of the children who had COVID-19 tests and they were confirmed, 0 of them had died. So in order to understand how we can support or what we have to do to support MSF projects, I will set the stage a little bit of what we have or the limitations we have in our projects. In terms of COVID-19, for most of our projects, we do not have a local capacity for testing in many of our sites. Most of the time, testing for COVID-19 is only available at the regional level or often at the national level. In the health facilities that we are typically working in, there is limited ICU capacity, and if there is any, and there's pretty much no ventilatory support in most of the places we are supporting. At best, we can provide oxygen and increase monitoring, and maybe some laboratory investigations, but not much more. In many of the settings we work in general too, we are also tackling endemic diseases. For example, in the Congo, we have had a measles outbreak for the last year that is still ongoing. We often work in areas where malaria is endemic, and in some areas in Central Africa and in the Sahel, this is the malaria peak. And we often have outbreaks of diseases like cholera also. Sadly, in a lot of our settings, we also have malnutrition, either chronic, like in Yemen, or seasonal, And once again, the peak of malnutrition in a lot of the areas we're working in, like in South Sudan and the Sahel, are right now. Many settings we work in also have higher HIV and TB prevalences, which complicates the picture. And in many places we work, there is, in general, low attendance for preventive health care, meaning people don't come to the doctor unless they are sick with something. This also sadly includes low vaccination rates. And in the health facilities that we're supporting, the concept of an individual patient room is not very common. And so most of the places we support have large wards where patients are housed. So this is a busy slide, but thinking about the constraints we have in most of our settings, we also have to think about the other effects that COVID-19 has on child health in most of our settings. The main ones are the missed opportunities that we end up seeing due to the COVID-19 epidemic and the associated measures the government has taken. So there's prevention, missed opportunities in prevention, such as in vaccination and spaces for children so that they don't get abused or neglected. Treatments are going by the wayside too, because especially for killers like malaria, and mothers are not seeking care, so newborns are not getting essential newborn care. Some new developing infections and some chronic diseases are not taken care of because families are avoiding health facilities or cannot access health facilities. Nutrition we see is also becoming a problem, as some programs that were already there in the past are now disrupted. And also because of the changes or the economic crises brought about by COVID-19, there is new food insecurity, which is leading to more malnutrition. All of this together makes a picture where we have a risk of excess child mortality, and the Lancet recently predicted it could go up to 1.1 million additional child deaths, which is what we are concerned about. So taking all of those into account, we have had, and these are the questions that have been raised to me as someone who's advising, or I myself have thought about when I'm advising fields about COVID-19 right now. Some of the general questions we end up discussing or thinking about are patient circuits. Where do we put patients who are suspects or who are undergoing investigation for COVID-19? How do we isolate if we're going to? How do we know what our programs are doing currently? How do we compare that to a previous time before COVID? And how do we plan if we see any changes? What do we do about the regular child activities that we had going on in terms of making sure that we have protection for both our staff and for the children who are seeking care? And how do they access us now that there are restrictions in movement? And then how do we monitor the community to make sure there's nothing new or dangerous coming up that we need to address? Also, we have to think about what we need to say to the communities that we're supporting to help them to know when to access care and how to and what to do if there are barriers to their health care. The clinical questions that come up are unique also to our setting. Specifically, questions come up like with concerning how you can diagnose COVID-19 versus the other diseases we commonly see in our settings, especially if you have limited lab capacity and no X-ray. What does this disease do to malnourished children and children with sickle cell disease? We don't have a lot of information from developed settings about these groups of patients. So we have to try and understand and monitor it in the settings when they arrive there. How do we support fields in differentiating TB from COVID-19 in areas where there's a high TB burden? And then how can we diagnose and manage multi-inflammatory syndrome, which of course requires laboratory testing, and we do not typically have that in our setting. The answers we've ended up coming up with are typically very context specific, meaning that with the projects, we discuss what their particular constraints are, HR, space, and others, and then we try and figure out what would be a good solution that is safest and most feasible for their context. We try and help them to understand how to negotiate space for their pediatric patients, meaning that we help them to safeguard the essential services for pediatric patients now, and also if there are COVID-19 related activities or centers where children are maybe sent, we help them to negotiate that the children are not put with adults, for example, that there is appropriate care and appropriate staffing to care for the children in those places. We've been trying out in different places new models of care or modifications to help the staff to continue the care that we're providing, but in a different way, and help them to continue surveillance of the community, making sure that nothing new is coming up and no diseases are creeping in that are developing in the community. For us on our end, we keep reviewing the data that is available just to make sure that we know what is new in all the settings so we can be ready to share that knowledge. And it ends up being a lot of trial and error as we support the fields to understand how they can do their job with this added, with COVID-19 and how they can care for children with suspected COVID-19. So that's a quick summary. Back to you, Dr. Patterson.
Thank you so much, Dr. Ogundibe. I think it's really important that we're able to continue articulating the questions as you have, because I think we're often caught in a situation where the answers become the main goal, but we need to continue to ask the questions so that we understand what we need to do implementation research on and answer better for the future. So thanks for highlighting those. Next, I'd like to move on to Dr. Dineo Tahane. She's the Executive Director of the College of Medicine. So over to you, Dr. Tahane, thank you.
Thank you so much, Dr. Patterson, and thank you for the opportunity to be able to share our experience with you all today. I'm coming from a little bit of a different background and context. I work for Baylor College of Medicine Children's Foundation, Lesotho, as was mentioned. We are an NGO which has been operating in Lesotho since 2005. We primarily provide clinical services for children and families affected by HIV, TB, and related conditions. We operate 7 clinical sites throughout the country, which is the Kingdom of Lesotho. And we're actually part of a network which includes a number of programs throughout the region. We are a partnership between Baylor College of Medicine International Pediatric AIDS Initiative, which is BPI, and the government in Lesotho, the local government, government of Lesotho. So many of our sister programs are in the region, countries such as Botswana, Eswatini, Malawi, Tanzania, Uganda, and some others outside of the region, Argentina, Colombia, Romania, to name a few. And many of the challenges that I'll be talking about here and some of the strategies that we've been implementing as a country program are not unique specifically to Lesotho, but are shared by many of our sister programs in the BPI network. So as I mentioned, we are in the Kingdom of Lesotho. Lesotho is a small country which is completely surrounded by the Republic of South Africa. We are in Southern Africa with a population of approximately 2.1 million people. We are a lower middle income country with strained health resources, and particularly human resources for health are particularly strained in Lesotho. We have a significant HIV and TB burden. Our HIV prevalence in Lesotho is a little bit over 25%, which puts us at one of the top countries globally for HIV prevalence. In terms of preparation for COVID-19, the government actually initiated a national lockdown beginning at the end of March, which was aligned with the lockdown in the Republic of South Africa. And this was well before any cases were identified in Lesotho. We actually did not identify the first confirmed case of COVID-19 in Lesotho until mid-May. And identification of cases has been relatively slow because of limitations in-country testing. So we really only started as a country testing in Lesotho in the end of June. So currently we're at 52 confirmed cases as we speak. So some of the key programmatic challenges that we are having to deal with as an organization is really maintaining critical essential services. For us, that means HIV and TB service delivery, and really supporting the government of Lesotho to make sure that Lesotho doesn't lose many of the major programmatic gains in the HIV and TB sectors that have been achieved over the last few years. We are really focused on protecting the health and safety of our clients and our beneficiaries, and primarily protecting our HIV-infected patients from potential COVID-related complications, and those may be direct complications or indirect challenges that they may be experiencing. For example, interruptions in supply chain for their medications, which could be potentially devastating for them. So many strategies have been implemented in country. I'll just highlight a few. One is continuous health education for our patients, really primarily focused on COVID prevention, but also on maintaining good medication adherence, making sure that they continue with their chronic medications. We're trying to make sure that we minimize patient contact with facilities, and there are a number of strategies we've been utilizing to do that in country. These have been focused on scaling up multi-month dispensing for antiretroviral medications, community distribution of medications where possible, optimizing antiretroviral regimens so that patients can maintain good virological suppression, and focused clinical visits, so really scaling down our usual clinical visits and focusing on some of the key issues when they come to facilities so that they can get in and get out as quickly as possible. We've also been trying to provide as much psychosocial support as we can for our clients, and really managing their fear and anxiety during this time, primarily through virtual support, things like radio and TV messaging, WhatsApp group, SMS messaging, and scaling up our social media presence. There are a number of concerns that our health workers within the organization have expressed that we've seen over the last few months. Really, they're focused on how to best reach and support our clients, particularly during times when our clients are unable to come to us due to movement restrictions or other challenges on their side. Identifying COVID patients is a particular challenge or particular concern that has already been mentioned when testing is unavailable, and particularly at this time because we are in the middle of winter in Lesotho, so it's cold and flu season. We're seeing a lot of patients coming in with cough and flu-like symptoms, and our health workers actually have a lot of fear and anxiety over not being able to tell what's just a simple cold or flu versus a potential COVID suspect. We are seeing a lot of fear and anxiety amongst our health workers, and I have highlighted some of the factors that are contributing to their fear on the slide here, but I just wanted to place a particular emphasis on one which is particularly challenging to us. As I mentioned, the HIV prevalence in Lesotho is very high at 25%. So that means we have a significant number of health workers, whether health professionals or lay health workers, who are HIV infected themselves and living with HIV. So we've had a lot of questions and a lot of concerns and fear and anxiety related to potential complications of COVID-19 for themselves as HIV infected health workers. Are they more susceptible to complications from COVID? We've had a lot of questions there and had to really provide constant reassurance to our health workers. We've also, as an organization, had a lot of questions about related to being exposed at work. So fear of death and dying, and what happens. Do you have funeral cover or death benefits, for example, as an organization? We're seeing a lot of those questions, which are really reflective of our health workers' anxiety overall. In terms of on a national scale, this is also continuing to manifest with Ministry of Health workers. During the month of April and partially during the month of May, there was a national health worker strike, and health workers were striking over lack of PPE, but also demanding risk allowances from government. This is something that has played out significantly on the national scale here in Lesotho and has had implications for us, primarily because our health workers were continuing to work. Our clinics remained open, and then they were seeing increased volume of patients because government health facilities were closed. So just trying to manage our health workers' anxiety related to those concerns has been a major factor. In terms of some of the strategies that we've been utilizing to support our health workers that have been particularly effective, one is really just demonstrating to our staff that we're trying to minimize their exposure as much as possible, making sure we make it a priority to keep them out of the health facilities as much as possible. We're encouraging staff rotations as much as we can to give people some days outside of the clinical setting, trying to decongest our facilities, get patients in and out as quickly as possible, and then actually expedite our patient visits and close our clinics early to make sure that people are able to get out and get home as quickly as possible to minimize their exposure. Another strategy which helped a lot was during our national lockdown, instituting a transportation system. So we would go around to different neighborhoods around the city and pick up our health workers to bring them to the clinics, just to really limit their exposure to public transportation. This really helped a lot in terms of making sure that they would feel less anxious, making them feel supported, and that we were really looking out for their best interests and trying to keep them out of the health centers. We also were very aggressive in working to procure PPE for our health workers, really ahead of the government system. So we are receiving PPE from the Ministry of Health as per other health facilities within the country. But well before that actually came about, we had already procured masks and hand sanitizers and other supplies to be able to provide to our own staff, just to sort of give them the feeling of protection, support, making sure that they realize that we are looking out for their best interest. We have relatively liberal guidelines for staff use of PPE to make sure that really anyone who feels that they are in need of PPE is really able to get it through us. Our supply is not unlimited, as you can imagine. We have funding limitations, but now that the government system has really kicked in and is starting to provide more PPE supplies for our health workers, we're finding that that initial investment up front to make sure that we were aggressive in providing it for our staff really has helped. Some of the other strategies that are helping us in terms of supporting our health workers is really having a COVID-19 response committee, which is multidisciplinary, making sure that departments throughout the organization are represented so that their needs can be addressed at an institutional or organizational level. We've tried to liberalize our policies on sick leave and making sure that people aren't going to be penalized if they call out sick or if they are concerned about their symptoms. We instituted a staff telemedicine service so that we have some providers within the organization who are available to consult with our staff members if they wake up and are not feeling well, to really touch base with them and provide guidance and support on whether they should come to work, whether they should go to seek care at another health center, or sort of just giving them additional guidance and support, which has helped. We've been providing training to our health workers to make sure that even well in advance of the government training on COVID-19 guidelines in country, we were already starting to train and provide education for our staff within the organization. And another big one has been mental health support. We've been achieving this through various different means, including WhatsApp groups, making counseling services available, debriefing sessions, frequent reassurance and education to our staff, encouraging self-care. And another one which has been big throughout the BPI network is leadership support and really sharing best practices and what's happening in all of the different countries within our network has been really very helpful amongst our executive directors and the COVID focal persons. So those are some of the things that have been working for us. Thank you so much, and back to you, Dr. Patterson.
Thank you so much, Dr. Tahane, for all of that detailed analysis of the actions that you're taking. It's my pleasure now to introduce Dr. Steve Wall, who's the Senior Director of Newborn Health for Save the Children. Over to you, Dr. Wall.
Thank you. I'm going to share with you the challenges and potential solutions for health providers, and particularly focusing on newborn health care during COVID. We have a program at Save the Children. Next slide, please. We've had a program called Saving Newborn Lives, funded by the Bill and Melinda Gates Foundation since 2000. And so we've worked in over 20 countries in newborn health over the years. And so that is really the basis of what I would like to describe today in terms of a response to COVID. Is really from that perspective of newborn health. But I do want to mention that Save the Children has a very large global reach as the largest NGO serving children. And we have health programs in about 30 countries, and we have specific maternal newborn health programs that involve COVID in most of those countries. Those do include countries that are humanitarian or complex settings. We also work in development settings. So my perspective today is more on the development side of things. Next slide. So the objectives are to describe what we know about COVID and pregnancy, delivery, newborn care, and the implications for healthcare providers, and then to describe Save the Children's priorities and approaches to support and empower governments and healthcare providers to address the needs and gaps in newborn healthcare in the face of the COVID pandemic. Next. Sorry, that was it. And so let me, leave that there. I don't have slides at this point, so I'm just going to speak, and you can please follow along. So with respect to what do we know about COVID and pregnancy, I think it's already been stated and everyone is aware that there's little direct impact on newborns that's been demonstrated without any evidence of vertical transmission and also no evidence of transmission via breast milk. There's been some recent suggestions that COVID may impact pregnant women more aggressively than non-pregnant women. There's even been some recent evidence around the potential for increased preterm birth among women that are infected with COVID. But by and large, we're talking about the effects on newborns being driven by the indirect effects of the pandemic and the pandemic responses in countries. WHO recommends really continuation of essential services, such as non-separation of mothers and babies, immediate and exclusive breastfeeding to continue, and skin-to-skin care immediately after birth to also continue, and then also kangaroo mother care for small and preterm babies. Clearly, there is also a need for testing where possible. And then if mothers are known to be COVID positive or have symptoms of COVID, then they should continue to breastfeed, provide skin-to-skin and KMC, but use strict hygiene and face mask to protect from transmission. But the breastfeeding and the skin-to-skin contact, KMC, are really considered essential interventions that should not be interrupted on the basis of COVID, unless, of course, the mother is too sick to practice those behaviors. So as has been said, the major impact is these indirect effects due to service delivery interruptions and also changes and impacts on caregiver practices for newborns. We have seen in our various programs more anecdotal reports of the some declines in services, and these have actually been quite alarming. I just want to note some of those that we have been seeing and hearing about that are I think leaving a population that's already vulnerable even more vulnerable. Decreased facility births and care seeking from facilities around the time of birth, and also for sick newborns has decreased. We've actually heard reports that as many as much as 50% of facility deliveries are happening in some countries. So we're seeing really dramatic decreases in facility deliveries in some places with an increase in home deliveries, and presumably that is posing risk to the babies and the mothers. But there are, of course, ways to mitigate against the lack of protection in facilities. Yet we see that fears and lack of equipment and lack of availability of staff have really impacted the trust and the availability of delivery services in facilities. The inappropriate and unnecessary separation of mothers and newborns after birth in facilities seems to be, unfortunately, too commonplace. We hear reports of this, and in some settings, we are facing situations where mothers and newborns have traditionally been separated and by facilities, and we've just made progress over the last several years in making sure that there is non-separation of mothers and babies. So whereas these practices are relatively new in many settings, the COVID pandemic has actually set us back, and we've seen really a retrenchment in the use of these essential services where we've been working hard to institute them. We definitely have seen decreases in immediate skin-to-skin and breastfeeding and decreases in KMC. So these reports from countries leave us really quite startled, and there have seen reports that some countries are doing better than others. We're not quite sure why that is and what are those factors. It's clearly context driven, and so at this point in time, we appreciate that there are a lot of variables and factors that we don't fully understand, and therefore are still trying to understand, what are the best approaches that we would take. I do want to just mention the JHU study that was published in Lancet in May that was referenced by the first panelist, showing the model estimate of additional deaths due to decreased use of evidence-based essential maternal, newborn, and child health interventions. They examined 3 scenarios of reductions in coverage of 77 evidence-based interventions for maternal, newborn, and child health. And they looked at a 5% reduction, a 10% reduction, and a 25% reduction in coverage of these essential services, and then calculated through the LiveSave model the potential lives lost, excess lives lost. And the numbers were already mentioned, but I would just say that it was really shocking to me to appreciate that even a small 5% reduction in these services would result in an estimate of 42,000 deaths per month. That is a startling figure. This is for 118 of the countdown countries, which are 118 low and middle income countries. And the highest, which is in the severe category of 25% reduction of services, there were almost 200,000 deaths that would be expected or predicted by the LIFT model per month for these 118 countries. So very startling numbers. So what are these approaches that we are implementing? Because we work not so much in direct service delivery in our development settings, our real efforts are to work to support and ensure governments follow national global guidelines and establish national guidelines consistent with best practices. So we are working first to ensure that governments are aware of WHO guidelines for MNCH service delivery, and that we're also working with the governments and their professional associations and key implementation partners to actually help understand how to implement these guidelines and to minimize disruption of essential MNCH services. The preparedness of health workers is a big issue that we are working to find ways, again, context-specific solutions to ensure that health workers are aware of what they should be doing, what are some of the optimal practices, and they implement and use those. We also have been working with our partners in country to develop and implement decision support tools, particularly for program managers who are planning the services that they are providing. And in this case, we are looking at trying to ensure that there are tools that help ensure the continuity of antenatal care, the care around delivery, postnatal care, and then the care of small and sick newborns. We also are trying to ensure safe work environments, with personal hygiene, PPEs, through various means, depending on the country and its procurement processes. And we've seen ubiquitously the anxiety and fear that has been mentioned previously. So working in finding local solutions for stress management and burnout prevention, and really trying to provide emotional and mental health support as can be done in the various contexts in which we work. Task shifting also where possible.
Mm-hmm.
Task shifting. Sorry. Task shifting, I just want to mention where possible. So task shifting is, of course, trying to facilitate that some of the workload can be shifted from, some of the core staff, such as midwives and nurses, perhaps to community health workers or other auxiliary workers. And one of the things, for instance, that we have been seeing and have been encouraging and working with governments to develop are plans for early discharge from facilities. But in doing so, we don't want to put the babies and mothers at risk. So we are trying to arrange as safely as possible also to ensure that there is contact with community health workers who are able to be in the communities and therefore not have to travel distances or deal with some of the concerns in the facilities and be able to make home visits. So this is one of the areas in which task shifting seems to be able to be effective. We're working, I would also say, to try to support more use of telemedicine in various countries. Again, the technologies are variable, and so there is opportunity in a number of countries that we're now developing and exploiting. And we've established research priorities for Save the Children, specifically, and to have a common learning agenda. But primarily, we are focused, at least on the maternal and newborn health side, on trying to understand the extent of disruption of essential services, really understand the drivers of those disruptions, and then identify and test approaches that would ameliorate these service disruptions.
I think that's really one of the key points. I'd love to just end on that point if we could, Dr. Wall.
Excellent.
That's
my last point, yes.
Okay. Did you want to make a summary remark? I'm sorry.
No, I just wanted to say that I think that we actually, unfortunately, have a lot more to learn. We're, I think, being able to conduct research, however limited, is going to be essential in helping to understand some of the solutions that ultimately will work and work well.
Absolutely. Thank you so much. Thank you for highlighting the work of Save the Children and also how countries are struggling to meet the WHO guidelines. I think we're also cognizant of the fact that some countries have chosen to develop national policies that may differ from WHO guidelines, such as the U.S. So I think it's important that countries continue to be in sync with the national priorities with guidance from global organizations whenever appropriate. So next we get to hear from the experience in India with Dr. Vivek Virendra Singh. He's a health specialist at UNICEF India, and we look forward to hearing how you're solving COVID problems. Thank you so much, Dr. Singh. Over to you.
Thank you, Dr. Patterson. And first of all, let me take the opportunity to congratulate the American Academy of Pediatrics for putting up a series which has such pertinent topics. And I'm very glad today that we would be speaking about the healthcare workers and their role, especially UNICEF, which works with a child rights perspective. So as we are all aware that the Convention of the Rights of the Child, they mentioned that there are certain children's rights which are enshrined in that convention, and all the states that are signatory to it, we support states in ensuring that those rights are met, and especially the right to survive and thrive, and which is so critical in these times of pandemic. But it makes the speakers before me have made my task very easy. And let me just put 2 or 3 things in perspective. So let me first pick on something that you said in the very beginning, that the American Academy of Pediatrics would also like to engage more with other countries in the world. So while this pandemic has thrown an unprecedented challenge to the humanity, and especially if it comes, let's say, once in a century. But as you rightly said, what the opportunity it has also given to humanity is to unite and show solidarity. And I think when we are going to speak about the healthcare workers, there is an opportunity to show this solidarity through science, because we have been seeing that the issue of governance, which was rarely taken into account many a times at many places, right from the local level to the top level, is something which needs to be studied after the pandemic if we decide to take stock. But yes, and I extend the invitation that there are local national neonatology forum chapters here and the Indian Academy of Pediatric forums. that are having exchanges with scientists from across the globe, and it will be very interesting to listen to each other and show this solidarity. So I will just pick one thing from what our previous speaker mentioned about the issue of breast milk. So if I want to put this into perspective about what we are doing in COVID times, so let's take this as an example. In India, with its birth cohort of 25 million children that are born, which exceeds maybe the population in most countries in the world, 43% of those children, which is 11 million kids, do not get breastfed at the time of birth. And I think 11 million also might be exceeding the population of many countries that we speak to. So let's take this issue. And again, another fact is that 30 to 50% of the preterm kids, which are in the neonatal intensive care units, do not have access to breast milk. So if we take this as a factor, so how we are supporting the healthcare workers in these trying times is that, let's say the WHO in February released that policy that it's safe, there is no transmission through breast milk, it's safe to room in the children after birth with the mothers, but it would not translate immediately into practice. And let me give some supply and demand side issues and why it wouldn't happen immediately. So it's easy to give guidelines, but there is apprehension and fear of a new disease. So even if the guidelines translate, let's say, as a previous speaker very rightly mentioned, we support governments in translating these WHO guidelines into national guidelines, putting in context. But what happens after that when implementation reality begins? That people are fearful about this disease and they would still not like to room in the baby. Second is, let's compare two states. If a state has less testing than the other states, and many of the healthcare workers do not know the status, let's say, of a mother who seemingly has symptoms, they might still fear to room or the baby with the mother and take that additional risk of ensuring that they have to invest more time to be with them to ensure infection prevention control in those settings. So what UNICEF does is, it is trying to engage the professional agencies, another opportunity which the pandemic has offered, for example, the APEX Institute in India, All India Institute of Medical Sciences. So that is mentoring district level hospitals, which are units. Districts in India are administrative units, you can say, akin to county in the US. So they are talking to the healthcare workers, care workers, that why it is good to room in and why simple thing as breastfeeding or kangaroo mother care for that matter is so important to save those additional projected lives. And another important point, as somebody mentioned, that the healthcare workers are apprehensive themselves because of the additional risks they have. So what UNICEF is also doing, it is working with the National Institute of Mental Health and Neurosciences to deliver packages for psychosocial care to healthcare workers. And the kind of scale that is possible in a populous country like India. So we could, like just yesterday, I was at a session where 92,000, about 100,000 healthcare workers across one of the most populous states of Bihar, they were linked to a session with this mental health institutes where psychologists were talking to them about psychosocial care, how to first maintain their own well-being. Another issue was that stigma and discrimination was jeopardizing the disease response more than any medical side of the issue. So what we have done is we're helping the government to launch on a nationwide campaign to stop the stigma and discrimination against anybody who's perceived to be a transmitter, so to say, of the disease, and it could also be healthcare workers. Many of the healthcare workers were assaulted also in India. And somebody very rightly pointed out that in developing countries and most of the settings in the world, the healthcare workers are not receiving the remuneration they should be, and there is scope to increase their incentivization. Let me put another thing into perspective just to end what we can do to support the healthcare workers is the issue of a simple thing as infection prevention control. So what UNICEF does in India is, as part of the Global Quality of Care Network, there is this Quality, Equity, and Dignity campaign where we try to inculcate through capacity building of healthcare workers, the ability to provide respectful care around the time of birth. And wherever we have supported this program in the last couple of years, which was a program of the Government of India, the facilities are performing better even in the times of COVID response. And one last point I want to make regarding, because we are speaking maybe to an audience of pediatricians and neonatologists, what we learned, and this is relevant to most developing countries, that most of the newborn deaths, for example, India, about 600,000 kids die every year in their newborn period, and which is 22% of the global. And out of the 5 countries that have maximum death, it amounts to almost 4 of the other countries, which are Pakistan, Nigeria, DR Congo, I believe, and Ethiopia. So what India learned was that newborn care, most of the deaths are happening because of lack of access to newborn care, and we know the abysmally low number of specially trained pediatricians and neonatologists. So some of the approaches which were tested and found out were easily saving lives were using the community health care workers. And that's precisely what we are trying to do now, that we're trying to leverage the opportunity of during the lockdowns of families being home to at least make sure that this home-based newborn care and opportunities for early childhood development are leveraged so that we can minimize as much as possible all the indirect effects that might be there on children's survival and how they thrive. So these are some of the things, and what I would definitely say to end on a positive note is that I would again just take 2 examples, that with the increase in all the ventilators, for example, in India, many of the lives which were being lost to diseases like, let's say, acute encephalitic syndrome every year, due to lack of the intensive care in many of the pediatric units in the district hospitals. Now those units are flush with ventilators, including pediatric intensive care units. Another important opportunity, the way we are communicating from 5 different countries today on a webinar. So APEX institutes like All India Institute of Medical Sciences are actually talking to the healthcare workers, which may be actually serving the last child, as we call. And in India, we have started the campaign, let's say the last girl child, because we have seen how this pandemic has brought to the light an existing equity issue. And for example, only 1.3% children in the US may be starving against 43.5% in India who are starving. But if you would dig deeper, even in the US, you'll be able to see if there's an equity issue and certain ethnic groups and minority populations may be suffering more than the others. And the same is the issue here, that within those kids who are likely to be impacted, there is definitely an issue of equity when we would dig deeper. So we're trying to reach these last child by empowering these health workers. So this is it, and thank you very much for the invitation, and I would be happy to take any questions.
Thank you so much, Dr. Singh. I think it's always important to hear a variety of country experiences, and I know the magnitude of your healthcare system in India makes it a very special kind of challenge that perhaps is a bit different from what you face in Lesotho. But I'd like to take one of the questions from the chat box now and talk about Lesotho again. If you would, Dr. Tahane, there was a question in the chat box about how you're planning ahead for disruptions in preventive and chronic care, which of course is at the heart of care of HIV-positive patients. And if you had a crystal ball, how long do you anticipate this disruption may last?
Thank you so much, Dr. Patterson, and thank you for the question. Lesotho's in a bit of a unique situation in that really we in country feel that really we're just at the beginning of this in Lesotho. As I mentioned, we're only at 52 cases confirmed in country right now. And so really we're starting, we've been dealing with this for a long time. We've been trying to educate the public and provide information for our health workers for the last few months, but really we're just starting to scale up in terms of numbers of cases. In terms of chronic care and preventive care, really the core of what we've been working on as an institution and the messages that we've been hearing from our health ministry is really just putting systems in place that are going to carry us through our new norms. So for example, when we talk about the large numbers of HIV positive patients in country, they're going to need continued access to their antiretroviral medication. So we're working on scaling up systems for community medication delivery, trying to be innovative in our approaches, whether that's community service delivery points or mobile facilities or other innovative strategies to really ensure that we get these systems in place before we start seeing large numbers of patients or larger numbers of patients coming in sick to health facilities, to really emphasize that we ensure patients are aware of what key changes there have been to the health delivery system and how they can take advantage of them. We are, in terms of the question about the timeframes and having a crystal ball, it's really very difficult from our standpoint because we really just don't know the scale of the problem in Lesotho yet. As I mentioned, in-country testing really just started, and at this point we're primarily starting with the patients that are coming across the border from South Africa. There is a lot of movement between Lesotho and South Africa, which is the country with the highest burden currently on the continent. So we haven't really started to test large numbers of people in country. It's very challenging to get a handle on the timeframes that we're looking at. I think most of us in country are concerned that this will be that we'll be seeing reverberation from some of these challenges for the next year or more.
Mm-hmm. Thank you so much. I'd like to come back to Dr. Singh, and I think Dr. Tahane emphasized really the challenges in continuing to provide this ongoing care. Luckily in Lesotho, you haven't had the massive surge in cases that we've seen in other places. But for you, Dr. Singh, I know you talked about the importance of getting out messaging, and you've also talked about task shifting, and there are questions about both of those in the chat box. So I'm wondering if you could address some of the challenges of getting messages out and in task shifting.
I think those are two very pertinent questions. So as far as task shifting, again, let me give some numbers. When, let's say, go back a decade ago, when at the district level, we did not even have the capacity to manage sick newborns at the district level with baby warmers. In the last decade, India has made progress to what we call the sick newborn care units, to have about 856 newborn units, which this year they had about 1 million population being served. So 1 million children in these units that were admitted. And there were already a lack of 60% of these units did not have the number of pediatricians required in shifts. And with some of these states, especially urban area, one very important issue this pandemic has brought to the fore is how the issue of resilient cities and the primary healthcare and healthcare infrastructure in urban areas is important. So many of these units, and especially in district hospitals, when they were made dedicated COVID hospitals, many of these pediatricians had to be shifted to either COVID duties. So what happened then was, then as somebody also mentioned, so these AIMS and other Apex institutions are working in hub and spoke model to provide a clinical care support to these units. And this was some direct mentoring with the task shifting. This was very important because the people, the healthcare workforce had to be trained very quickly. And there was never a pandemic preparedness approach where you would think of staff surge, so to say. And most of the countries, I think, are facing this challenge that people did not understand the importance of, let's say, take influenza pandemic preparedness plans, that how do you account for service continuity and the indirect impact. So two things that have happened, that are happening now, MBBS physicians, the general physicians, they were trained for specialized pediatric care for these units. Nurses were trained, but at the same time, through telemedicine, through a hub and spoke model, institutions at the state level and national level, they are connecting to the institutions in the district and sub-district level. And what was the other part of the question?
Just about task shifting, and then I think it's also linked to the way you're distributing messages and getting the messages out.
Messages to?
Messages to communities.
Okay. Now, what has happened is that the response, and this is true for most of the places, the response to the fact that there could be more lives lost due to disruption of services was reactive. And there are very few states in India, although there are states where it was proactive and preparedness based. I'll take in global example that countries that had suffered SARS and MERS, they knew how to communicate. So risk communication and community engagement in these countries. Similarly, in India, states that had recently suffered a Nipah virus outbreak and also have some of the best social indicators. From day one, they had a very robust risk communication and community engagement plan. And they are the ones who are actually, so to say, flattening the curve and managing it well. So different states are in different settings, but that's how through a comprehensive risk communication and community engagement plan, there are partners like UNICEF and SAVE and BMGF that are trying to support the government's initiative of risk communication and community engagement for ensuring that essential services are available and availed by the citizens.
Thank you so much. I'd like to come back to Dr. Ogundipe. I know that MSF is really a master of supply chain and getting things out to many countries under many challenging circumstances throughout the world. And personal protective equipment has really been a challenge in so many countries, high-income countries as well as lower-income countries. And I'm wondering if you can just speak again to how MSF is approaching this job of keeping so many healthcare workers protected through this pandemic.
Thanks for that question. Yes, it is a challenge, especially it was a huge challenge at the beginning because this wasn't a regional problem, it was worldwide. So we had from the beginning issues of being able to export PPE from regions like from the European Union where it was blocked because they were scared that they would need it here. But we were able to negotiate and plan from the stock that we had in Europe and other sites to get them to the places we needed them to be. Thankfully, for some of the sites we were already at, like in Nigeria where there's Lassa fever and in DRC where there's Ebola, and in Sierra Leone, there is a stock of PPE that was already there in our emergency prep package that we were able to plan to use for this kind of situation. But of course, with opening that package and using it for this, we had to now plan ahead for what would come next. So far, at the beginning was very challenging, but so far we've been able to either devise a way to get the supply moving, or also we've been able to work with our infection prevention and control specialists to have a cascade of for the setup to decide if you have this level of PPE, this is what you do. If you do not have that level, this is what you do next, and how to help the staff to, at whatever level they find themselves, provide the optimal protection that they can get. We've used some of the WHO guidelines, including the cloth mask use, but we've just had to be creative in some ways to say, this is option A, this is option B, and if all else fails, this is option C. One thing that we are also trying to make sure we push for is that the community health workers also, not just in the facilities, are protected. And this, I think, ends up being something that sometimes we can easily forget, but we've been pushing to remind that if we are going to be successful, especially for child health, we have to protect the community health workers also and make them protocols that are protecting them effectively.
Thank you so much. There's another question that came up in the chat box that I think I'm going to use that to wrap up today on this webinar that asked what kind of support we can give to our younger healthcare workers. Many of you know that this week in the United States is the day that all of the new interns start. And I think in many countries around the world, taking care of COVID positive patients as the start to your medical career can be so very daunting and challenging. And so I hope that as we think about healthcare workers writ large and taking care of our patients, that we also have a special spot in our heart to protecting our young healthcare workers as they launch their careers and do what we can to support them and protect them. So I think I'll hand it back over to Dr. Paula D'Souza to make any closing remark and to update us about the next webinar. Thank you so much, everyone, for joining us today.
Yes, thank you to everyone for joining, and thank you for our wonderful panelists. Please save the date for our next webinar, which is on July 14th. As you can see, it will. The topic is acting on health disparities locally and globally, where to start. So please make note of that. We will send an email to everyone who registered for this listserv with the registration details. So keep an eye out for that, and we hope you are able to join us. It will also be recorded, as is this webinar, so you can refer to it later as well. Thank you so much.